If you've ever received your cholesterol results and focused only on whether your total cholesterol is high or low, you're not alone. And if you've ever been told your cholesterol is fine for your age, this video may fundamentally change how you understand heart attack risk. Because one component of your cholesterol panel is far more predictive of sudden cardiac death than most people realize, especially after 60. And focusing on the wrong numbers has quietly put millions of seniors in danger. Let me make you a clear promise right away. By the end of this video, you'll understand which cholesterol number is actually dangerous for seniors, why it becomes more critical as we age, and how many people are falsely reassured by acceptable total cholesterol while arterial damage is already progressing. This is not about creating fear, it's about precision, and precision prevents heart attacks. I'm Dr. Catherine Wells. For decades, I've worked with older adults who did everything right. They checked their cholesterol regularly, they took their statins faithfully, they followed dietary guidelines, and yet, many still experienced heart attacks, required stents, developed heart failure, or died suddenly. When we examined their medical histories closely, the issue wasn't that they ignored their cholesterol, it was that they were monitoring the wrong component, and no one explained why that distinction mattered. Before we continue, I want to ask you something important. When you review your cholesterol results, which number captures your attention most? Your total cholesterol or your LDL? Most people instinctively focus on total cholesterol. They're told that's the primary risk indicator, and for decades, that was considered sufficient. But aging changes the risk equation. Let me tell you about a patient named Margaret. Margaret was 71, active, and meticulous about her health. Every 6 months she checked her cholesterol and confidently told me, "My total cholesterol is excellent." Her total number stayed comfortably under 200 for years. But her LDL cholesterol, specifically her small dense LDL particles, had been steadily increasing. Her triglycerides were climbing. Her HDL was dropping. Each time she was reassured that happens sometimes with age. Until one afternoon Margaret suffered a massive heart attack that no one predicted. Here's the uncomfortable truth. Cholesterol is not just one simple number. It's a complex story about inflammation, arterial damage, and metabolic health. And one component of that story predicts cardiovascular events much more accurately than total cholesterol alone, especially in later life. When you measure cholesterol, you're actually measuring several distinct components. Total cholesterol is simply the sum of all cholesterol in your blood. LDL cholesterol, often called bad cholesterol, carries cholesterol from your liver to your arteries where it can accumulate. HDL cholesterol, the good cholesterol, carries cholesterol away from arteries back to your liver for disposal. And triglycerides are a type of fat in your blood influenced heavily by diet and metabolism. For decades, doctors focused primarily on total cholesterol and LDL cholesterol. But advanced lipid testing has revealed something critical. Not all LDL particles are equally dangerous. Large, fluffy LDL particles are relatively harmless. Small, dense LDL particles are highly atherogenic, meaning they easily penetrate arterial walls and trigger inflammation and plaque formation. Here's the part many people miss. You can have acceptable total cholesterol and even normal LDL cholesterol. But if your LDL particles are predominantly small and dense, your heart attack risk is substantially elevated. And these dangerous particles become more common as we age, especially with metabolic changes, insulin resistance, and chronic inflammation. Why does this happen? Because traditional cholesterol tests don't measure particle size or type. They only measure total quantity. It's like counting all cars on a highway without distinguishing between compact cars and massive trucks. The total number might look fine, but the trucks cause far more damage. This is why cholesterol is often called a misleading metric. It doesn't fail dramatically, it fails subtly. And the component most people ignore, LDL particle size and density, is usually the most critical warning sign. Now, here's an open loop I want you to hold on to. If small dense LDL is so dangerous for seniors, why are so many people never tested for it? The answer lies in outdated testing protocols and misunderstanding what normal really means at different ages. Many seniors are told that a total cholesterol of 180 or LDL of 110 is acceptable. But research has consistently shown that the quality of LDL particles matters more than the quantity, especially after 60. At the same time, there's another trap. Aggressively lowering LDL with high-dose statins can cause muscle damage, cognitive issues, and liver problems. Some seniors experience debilitating side effects while their advanced lipid profile, the one that actually matters, barely improves. So now we have a dangerous disconnect. Standard cholesterol targets may not prevent heart attacks. Aggressive statin therapy may cause harm without addressing the real problem, and many seniors are caught in the middle without anyone explaining what's truly happening. This leads us to an important concept that almost no one discusses outside cardiology circles: the triglyceride to HDL ratio. This simple calculation provides remarkable insight into metabolic health and cardiovascular risk. For example, if your triglycerides are 150 and your HDL is 40, your ratio is 3.75. A ratio above 3 indicates insulin resistance and predominance of small dense LDL particles. A ratio above 5 signals severe metabolic dysfunction. Many seniors have elevated triglyceride to HDL ratios without ever being told it matters. This is why someone with total cholesterol of 170 but a ratio of 4 may actually face higher risk than someone with total cholesterol of 220 but a ratio of 2. The second result looks worse to most people, but the first reflects metabolic dysfunction and dangerous LDL particle patterns. Here's where confusion deepens. Some people try to lower LDL by adding multiple medications that create side effects without improving particle quality. They feel weak, experience memory problems, or develop muscle pain. They assume it's aging when in reality their treatment is missing the actual target. This is why cholesterol management in seniors must be individualized and sophisticated. One-size-fits-all LDL targets don't work. Numbers on paper matter, but particle characteristics and metabolic health matter more. Let me ask you another question. Have you ever felt muscle weakness, memory fog, or unexplained fatigue after starting or increasing a statin? These can be signs that medication dosage is too aggressive for your individual metabolism, even if your LDL number looks better. Now, let's return to the core question. Which cholesterol component is actually dangerous? For most seniors, the quality and size of LDL particles, combined with the triglyceride to HDL ratio, are the primary threats. These markers predict heart attack risk far more accurately than total cholesterol or even standard LDL measurements. Total cholesterol still matters, but its role diminishes with age. The goal is not to achieve the lowest possible LDL number. The goal is to shift LDL particle distribution toward larger, less dangerous particles, while improving overall metabolic health. Here's another open loop. If LDL particle size is the main danger, why do some dietary changes lower total cholesterol but barely affect particle distribution? And what actually transforms small dense LDL into larger, safer particles? That's what we'll cover next. Because in part 2, I'm going to explain why LDL particles become smaller and more dangerous, even when total cholesterol stays stable, what actually improves particle size distribution, which lifestyle changes are supported by research, and why some cholesterol medications help seniors, while others quietly cause harm without addressing the real risk. Before we move forward, I want you to remember this. Cholesterol problems rarely announce themselves with symptoms. They don't cause pain. They don't give warnings. And the component most people never measure is often the one that matters most. Now, let's talk about what actually helps. Because understanding which cholesterol component is dangerous is only useful if you know how to address it. This is where many seniors feel frustrated. They're told their cholesterol is elevated. They're prescribed a statin. And yet, they still don't feel optimal, or the numbers improve superficially, but particle quality remains unchanged. That's not success. That's incomplete treatment. The first thing to understand is this. LDL particle size and distribution behave differently than total cholesterol, and they respond to different interventions. Trying to manage both the same way often creates problems, especially later in life. Small dense LDL particles are driven largely by metabolic dysfunction, specifically insulin resistance and chronic inflammation. As metabolism becomes less efficient with age, the liver produces more small dense LDL particles. They're more likely to oxidize, penetrate arterial walls, and trigger plaque formation. That's why LDL particle distribution worsens with age even in people who maintain stable total cholesterol levels. This also explains something many seniors find confusing. You can have perfect total cholesterol and still develop coronary artery disease. There may be no warning signs, no symptoms, no obvious risk factors. That's why relying on total cholesterol alone can be dangerously misleading. One of the most effective ways to influence LDL particle size is improving insulin sensitivity. That means reducing blood sugar spikes, lowering chronic inflammation, and addressing metabolic syndrome. This is where lifestyle plays a profound role, often more powerful than medication alone. Let's start with carbohydrate quality. You do not need to eliminate carbohydrates completely to improve LDL particle distribution. What research consistently shows is that replacing refined carbohydrates with fiber-rich whole foods shifts particle size toward larger, safer LDL. Even reducing added sugars and processed grains while maintaining adequate vegetable and fruit intake can transform lipid particle patterns within weeks. Refined carbohydrates spike blood sugar and insulin, which directly triggers production of small dense LDL particles. Whole foods with natural fiber slow glucose absorption, improve insulin sensitivity, and reduce triglyceride production. All of these directly affect LDL particle distribution. The key is food quality, not calorie restriction. Now, let's talk about fats. One of the most misunderstood topics in cholesterol management. Some seniors are told to eliminate all saturated fat. Others are told fat type doesn't matter. The truth is far more nuanced. In metabolically healthy individuals, moderate saturated fat intake doesn't necessarily worsen LDL particle distribution, but in insulin-resistant seniors, saturated fat can increase small dense LDL production. The goal is not zero saturated fat. The goal is replacing poor quality fats with beneficial fats while addressing underlying insulin resistance. Omega-3 fatty acids from fatty fish, for example, consistently improve LDL particle size, reduce triglycerides, and increase HDL. This is far more effective than simply reducing total fat intake. Monounsaturated fats from olive oil, avocados, and nuts also improve particle distribution without raising LDL quantity. Exercise is another powerful modifier of LDL particle characteristics. Resistance training and moderate aerobic activity improve insulin sensitivity, which directly shifts LDL distribution toward larger particles. Even walking 30 minutes most days can measurably improve advanced lipid profiles. The key is consistency and modest intensity. Extreme exercise can temporarily raise inflammation and oxidative stress, potentially worsening particle oxidation. Now, let's address triglycerides because they're intimately connected to LDL particle size. High triglycerides almost always correlate with small dense LDL predominance. Lowering triglycerides through dietary changes, particularly reducing added sugars and refined carbohydrates, simultaneously improves LDL particle distribution. This is why the triglyceride to HDL ratio is so predictive. It reflects underlying metabolic health, which determines LDL particle characteristics more accurately than LDL quantity alone. Stress and sleep also profoundly affect lipid metabolism. Chronic stress and poor sleep quality worsen insulin resistance, increase inflammation, and promote small dense LDL production. Improving sleep quality and managing stress often improves advanced lipid profiles sometimes more effectively than dietary changes alone. Now, let's address medications honestly and carefully. Statins reduce LDL cholesterol quantity effectively, but their impact on LDL particle size is variable. Some individuals experience improved particle distribution on statins. Others see quantity reduction without meaningful particle transformation. This is why some seniors take high-dose statins, achieve very low LDL numbers, yet still experience cardiovascular events. The quantity improved, but particle quality remained dangerous. Another consideration is statin side effects. Muscle pain, cognitive fog, liver enzyme elevation, and increased diabetes risk are all documented. These side effects are dose-dependent and individual. For some seniors, moderate dose statins combined with lifestyle optimization produce better outcomes than high-dose statins alone. Other medications specifically target triglycerides or improve particle distribution. Fibrates, omega-3 prescriptions, and newer agents like PCSK9 inhibitors each work differently. Treatment should be individualized based on advanced lipid testing, not just standard cholesterol numbers. This brings us to testing and how cholesterol should actually be evaluated. Standard lipid panels measure total cholesterol, LDL, HDL, and triglycerides. Advanced lipid testing measures LDL particle number, particle size distribution, oxidized LDL, and inflammatory markers like high-sensitivity C-reactive protein. These advanced tests provide a dramatically clearer picture of actual cardiovascular risk. Two people with identical standard lipid panels can have vastly different advanced profiles, and therefore vastly different risk levels. Morning fasting samples are most accurate. Consistency in testing conditions allows meaningful comparison over time. Trends matter more than single measurements. A gradual worsening of particle distribution over months signals progressive metabolic decline, even if total cholesterol remains stable. Now, let's return to the triglyceride to HDL ratio, because this simple calculation often reveals more than expensive advanced testing. A ratio under 2 suggests healthy metabolism and predominantly large LDL particles. A ratio between 2 and 3 indicates moderate insulin resistance. A ratio above 3 signals significant metabolic dysfunction and small dense LDL predominance. For example, if your triglycerides are 200 and HDL is 40, your ratio is 5. Even if total cholesterol is acceptable, your metabolic health and particle distribution are concerning. This is actionable information you can calculate yourself from standard lab results. Now, here's something empowering. Small, steady metabolic improvements often produce meaningful lipid transformations over time. Better sleep, daily movement, improved carbohydrate quality, increased omega-3 intake, and stress reduction all work synergistically to shift particle distribution. None of these changes are dramatic, but combined they can transform cardiovascular risk significantly. Another important factor is visceral abdominal fat. Central obesity drives insulin resistance, which directly worsens LDL particle distribution. Even modest reductions in waist circumference can improve particle characteristics measurably. Alcohol also deserves mention. Excessive alcohol raises triglycerides and worsens insulin resistance. Moderate reduction often improves triglyceride to HDL ratios within weeks. At this point, I want to address a fear many seniors have. If my particle distribution is already poor, is arterial damage irreversible? Not necessarily. Arterial plaque has dynamic components. While calcified plaque is permanent, inflammatory soft plaque can stabilize and even partially regress with aggressive metabolic optimization. Improving particle distribution matters. Reducing inflammation matters. Preventing further damage matters. This is why cholesterol management is not about achieving perfect numbers once. It's about sustained metabolic health over years. Now, let's bring this all together. For most seniors, LDL particle characteristics and the triglyceride to HDL ratio are the primary dangers. Total cholesterol quantity is less predictive. Standard LDL targets may be insufficient. Advanced testing reveals the actual risk. Symptoms and quality of life matter just as much as numbers. Cholesterol is not a scorecard. It's diagnostic information. It tells you how your metabolism is aging and how your arteries are responding. Let me be very clear about something. You should never stop or change medication without medical guidance. But you should absolutely understand what your cholesterol components mean and request appropriate testing. Informed patients achieve better outcomes, period. And this understanding prevents unnecessary anxiety. Many seniors panic over mildly elevated total cholesterol while ignoring catastrophic triglyceride to HDL ratios. Others celebrate low LDL numbers without realizing their particle distribution remains dangerous. Knowledge corrects both errors. We've covered substantial ground, so let me leave you with the most important takeaway. Cholesterol danger in seniors is not about achieving the lowest possible LDL number. It's about optimizing metabolic health, improving particle distribution, and preventing the inflammatory cascade that causes heart attacks and strokes. It's about protecting your brain, your heart, and your independence. It's about preventing sudden events that change lives overnight. And now I want to end with one clear question. This is your call to action. When you review your cholesterol results, what is your triglyceride to HDL ratio? Calculate it and write your answer in the comments. Because the more you understand your lipid profile, the less power it has over you and the more control you regain over your cardiovascular health.